Sit down. You can imagine how excited, pleased, and blessed I am to be here. I'm going to tell you a story. I think this is too close. I'm going to tell you a story that exemplifies a teaching that a dear teacher of mine, cannot hear? A dear teacher of mine, Mr. Jack Hawley, gave me. He said, Swami puts, when something is needed, Swami will give. And so this is a story of how Swami gives what is needed. I retired about 2.5 years ago to do more service. That was really where my heart was taking to me. I had been blessed to be able to work in the Sri Sathya Sai General Hospital and in the gynae OPD for several years, and I was amazed that each time I would go for my 1 to 2 week sessions of seva, I would see 2 or 3 women with cervical cancer, invasive, bleeding, ugly cervical cancer. And in my own practice in San Francisco, where I was taking care of a population of insured women who had access to pap smear screening, I had seen only 1 woman ever walk into my office with a frank cancer. What I'm going to talk about very briefly in less than 15 minutes is the natural history and epidemiology of this disease. I'm going to talk to you about a low-cost and low-tech alternative to pap smear screening that can be brought to the developing world and trained locally to the healthcare providers in the developing world. So it is a sustainable screening program. And I'm going to show you some pictures of our recent first training at the Sri Sathya Sai Mobile Hospital in August. Next slide, I'll let you do it. Human papillomavirus. This virus is ubiquitous. Epidemiological studies in the US show that 80 to 85% of adults acquire HPV at some time during their lives. It's also important to know that the first infection is primarily in the first 10 years of sexual activity, and that most of us clear the virus. We get rid of it completely. Also remember, please, that you can be reinfected with a new strain of the virus at any point during life, during sexual life. There are 13 strains of HPV that cause oncogenic transformation of the cells in the genital tract, both male and female, but in the female it has more dire consequences. The virus is spread by skin-to-skin contact, so use of condoms does not prevent infection. As I said, immunocompetent individuals will clear the virus in 24 to 36 months. It is persistence of the virus that is the prerequisite for the development of cervical cancer. And there are certain factors which maximize persistence, and they are, as you can imagine, HIV or any source of immunoincompetence. Smoking has a very big impact on persistence of HIV, and we see this in our clinics here where women who smoke don't clear the virus, and it becomes one of the major reasons why I try to pound into these young women, stop smoking. The number of sexual partners a woman has a direct relationship with the persistence of HPV, and the number of sexual partners her partners has or has had will also impact that, as well as the age of first sexual contact. And this is important as I think about the young women in the villages who are getting married when they're 16 or 17 or even earlier. Finally, access to screening. And I will explain to you why access to screening is the thing we can really get our hands on and change. Next slide, please. There is a very, very long progression from the time of infection to the time of invasive cancer. This is a picture of the cervix, just with some vinegar applied. You can see it pooled at the bottom of the normal cervix on the right. In this 10, 20-year progression, there is first infection, then precancerous changes that go through mild, moderate, and severe dysplasia before it breaches the basement membrane and becomes an invasive cancer. It is ultimately treatable, curable, if we get at it sometime during these 10 to 20 years. The cervix is accessible, unlike the ovaries or the lungs. We can get at it, we can look at it. Also, the lesions that occur can be recognized easily, screened for, and easily removed. So it's the lack of screening that really determines the tremendous disease burden that is suffered by women in the developing world. Next slide, please. India fits into the category of a country with very high morbidity and mortality from cervical cancer. And there are numerous reasons. There are isolated rural populations. There's illiteracy, which makes health education, and letting the population know that this is a treatable cancer if women come in for screening, if screening is available, as opposed to the way it is now, where it's just thought about as a normal part of life in the villages. The other thing that I've really become aware of is that the mindset for prevention, and that's why this panel is so important. The mindset for prevention is not the priority in the developing world. The healthcare systems that do exist are flooded with taking care of acute problems. And both from the point of view of the populations as well as the point of view of the healthcare providers, prevention is not yet a priority. And so we, Swami through us, we have a lot of work to do. There are, in many, many countries in the developing world, limited access to cytology and pathology, and that's why pap smear screening as a strategy doesn't work very well. And of course, the burden of HIV will affect the prevalence of the disease, and more importantly, from my perspective, this rapidity through which disease progresses to cancer. Women who are HIV positive don't have 10 to 20 years. Just a very interesting fact. In Africa, where there is great effort being spent on getting people tested for HIV so they know their status, and where there's access to free ARTs, antiretroviral drugs, we are now seeing women die of cervical cancer, not of AIDS. Next, please. So, what to do? Well, I was not the first person to ask this question, not surprisingly. In 1999, the Gates Foundation put a lot of money towards creating an alliance of 5 previously existing organizations and agencies to find an alternative strategy to cervical cancer screening and treatment that would be applicable in the developing world. Next, please. The ideal strategy, as you can imagine, has to be at least as good as pap smears, which is not a great screening tool, but in terms of sensitivity and specificity, it has to be at least that good. It has to require minimal or no lab support. It must be easy to teach this technique to the appropriate providers. In many countries, especially in Africa and Central America, there's a real scarcity of physicians, and so we are training mid-level midwives, nurses, medical officers to do the screening and treatment. And it has to be portable. You have to take this treatment to where the people are. They're not going to get on a bus and travel to have screening. So you'll see we put everything that we need to do this work in 3 suitcases and bring it with us. And ideally, it's going to be done in a single visit, both the diagnostic screening and the treatment, so you do not lose people to follow up. Next slide, please. What we do is called VIA, or visual inspection with acetic acid. Acetic acid is vinegar. It's a very, very simple technique. With the trained eye, after the application of acetic acid, the cervix turns white if there are lesions. I'm going to just go to the next one, please. We don't need any colposcopes for the gynecologists in the audience. That's another heavy piece of equipment that can break, so we just train our eyes to look without magnification. And what we see is a well-defined white lesion. The one on the left is a mild dysplasia. The one on the right is probably a severe dysplasia. It's much thicker, and there are vascular patterns if you look closely. Next, please. When we find a lesion, we get rid of it using either cryotherapy or LEEP. Cryotherapy is simply freezing the cervix using nitrous oxide, portable tank, metal probe, put it on the cervix, freeze down to -90 degrees centigrade. The cells are destroyed. The other technique is LEEP, which stands for loop electroexcisional procedure. We use an electrical generator, a Bovie, as we use in any operating room, but it's a little tiny thing, doesn't weigh that much. You can schlep it with you. And we use a special kind of electrode, a wire loop electrode that looks like a styling tool for working with clay. And in that way, we can remove, cut out, excise, and cauterize at the same time. So we can do a minor surgical procedure with minimal blood loss as long as there's electricity. There is about a 1% significant bleeding rate after LEEP, and so we have to have, that's a procedure we only train physicians in because there may be a requirement for suturing or transfer to the hospital. Both of these procedures are 90 to 95% curative. This August, we did our first training, and this is our first day. We were welcomed. You are going to hear a talk tomorrow from Dr. Narasimhan, the director of the mobile hospital, and you're going to hear about the amazing work that they do. But every time the mobile hospital pulls into a village, it's as if Swami is coming to the village, and we were greeted with love. Next slide. We trained 15 doctors. We start training by didactic lectures, which is what happens here. We examined 355 women. We found 27 abnormalities and did 27 procedures. Unfortunately, we also found 6 cancers that we could offer no treatment for. Next slide. The woman who you see on the left is a patient who had just had her VIA and had a severe dysplasia. So the probability of that progressing to an invasive cancer is very great. We recommended that she have a LEEP procedure, and in this picture I am explaining to the 2 doctors how to counsel the patient and how to get informed consent for the procedure. Next slide, please. This is the founder of PINK, Dr. Kay Taylor, putting in the paracervical block, demonstrating treating how to put in paracervical block. Whereas cryo is painless, LEEP is painful and cannot be carried out without anesthesia. But a simple paracervical block with 1% lidocaine gives complete pain relief. Next slide, please. And this is a very important picture. This is the patient, the same woman. Now look at her face, and she is smiling, not only because the procedure is over, but because she has such gratitude for the treatment. And then if you look at the face of Dr. Kay, she is also smiling. And these 2 women shared love. Next slide, please. But there's the LEEP generator and the cryo tube is sticking up. So all of that equipment is now with the mobile hospital. In return for the training and the donation, we ask every trainee to continue doing screening. We also ask every trainee to become a trainer and to train others in how to do this simple procedure. In that way, we hope to prevent cervical cancer, one doctor, one woman at a time, and it is truly our goal to wipe cervical cancer off the face of the earth. It seems impossible, but with Swami, all is possible. Any delegates who are here who would like to talk to us about bringing the training to your medical systems, we'd be most happy to talk to you. Myself or John Adams, who's the administrative director, will be at our poster session. It's our passion to go wherever it is needed. Thank you, Saidam.